Hi everyone, and welcome to ABC's Anaesthesia, and I've got another junior anaesthesia Viva with Erica. Thanks, Erica. You've just been an absolute champion for coming on for so many of these episodes that I hope are going to help so many people. So thanks for your courage and bravery.
No worries. Thank you for doing it with me.
Hey, so today we're going to do like a pediatric Viva. So I'll just put the notes in the chat here. So this is the stem. And with this Viva, you get kind of 2 minutes reading time, as everyone knows. And then it'll be like roughly a 30-minute Viva. This one, I want to cover just lots of pediatric style topics. So we might just go on for a bit until we get to cover them. The disclosure is I write the RG, I've written a few RG exams or the GPA exams, but these Vivas are pretty much from my bank of Vivas, which I've just, changed slightly to make them, RGA compatible. But hopefully they'll be just really useful to anyone who's a junior trainee going through this any kind of exam process. So if you're just starting out in anesthetics, these are kind of the basic topics that everyone in their first couple of years will absolutely learn. But a lot of these things will also come up in, obviously, in real life. They're really common, but even in the final exams, you get questions like this. So hopefully this is useful for anyone. Great. So I'll start with the stem. And the stem is there. Just take a couple of minutes to read it. Actually, just as a learning point, Eric, in that 2 minutes with a pediatric Viva, what kind of things are you writing down, do you reckon?
Well, I'm writing them at the moment, so 8-year-old, 30 kilos. And then from there, I do some calculations. So I do the expected weight, which is age plus 4 times by 2. And I'm very slow at maths. It's going to take me a while.
It is 12 times 2, 25. Yep. I do times 2 plus 9, which would get to...
Everyone has a slightly different formula. So that gives me the expected weight. And then from there, I do the calculations for airway equipment. So age over 4 plus 3.5 will give you my ETT size. And then age over 2 plus 12 will give you the ETT depth as well.
So
that's what I'm just going to work out now.
I'll do all those things, 2 minutes. And I'll just read this out for everyone who's watching and listening. You're asked to anesthetize an 8-year-old boy for an elective tonsillectomy. He weighs 30 kilos. He's on no regular medications and has no known allergies. What do you want to know on assessment? So I'll give you as much time as you need. Everyone who's listening, watching, feel free to pause this. This will probably be kind of cut short in the actual video.
All right. I think I'm good to go.
Yeah, excellent. Okay, so what do you want to know on assessment?
Yeah, so on the assessment for this child, I would want to do a basic pre-anaesthetic assessment, including getting a bit of past medical history if he has any regular medications, although it says that he doesn't have any in the stem. Any previous anaesthetics he might have had, and if he's not had some, if there's any family history of major anaesthetic issues. I'd want to know what the indication for the tonsillectomy is. So sometimes in children, this can be OSA, and that may be the case in this boy because he is overweight for his age. The other indication would be something like recurrent tonsillitis. I'd also want to know a little bit about his birth history, at what gestation he was born, if there was any need for special care or NICU admissions, if there was any significant sort of antenatal history, and then a little bit about his growth and development to date, whether he's growing and developing normally for an 8-year-old boy with good exercise tolerance or whether he's got any functional impairments. I did mention he's overweight for age. Obviously, that depends on his height a little bit as well, but looking at the child and thinking about things like OSA or snoring, which may be the indication for the procedure, as well as other potential end organ effects from his him being overweight, so things like maybe potentially hypertension, although it's less common in children, just thinking about the other organ effects of that. I'd also want to know if he's had any recent upper respiratory tract infections, particularly in the last 2 to 4 weeks, as this has implications on anaesthetic planning and management for potential postponement of the surgery. In terms of the examination, I'd want to do a general inspection, get some vital signs, a height and weight for him if possible. I'd do an airway assessment as much as he is able to tolerate, although if he's 8 with no other behavioural issues, that should be fairly straightforward. And I'd do a cardiorespiratory examination, in particular listening for any undetected murmurs that might not have been picked up to date, and any wheeze or suggestion of asthma or viral-induced wheeze on respiratory examination. If there was any indication of functional impairment, I might also consider like sort of exercise tolerance, like getting him to walk up and down the hallway, see how he's going. And in terms of, the history as well, I'd want to know if there's any history of asthma, because that's very common in children of this age. And then in terms of the investigations, if there's been any polysomnography done for his potential sleep apnea or sleep disordered breathing, although I think in children it's more commonly a clinical diagnosis. So just finding out how that was diagnosed, if it's relevant, and if there's any investigations. Otherwise, unless I detected anything on exam, we don't usually need routine investigations for a child of this age.
Anything else that you do in the paediatric context on assessment?
Yeah, so I guess the other thing I'm really wanting to know is a little bit about this child's engagement and rapport, whether I can build rapport with him in the pre-anaesthetic environment. And I'd focus usually on the child first and speak to them, especially 8-year-old who should be able to talk to me if he's got no other impairment. So having a conversation with him, finding out a little bit about what he knows about the procedure, what he knows about anaesthetics, has he been told, or does he want to know a little bit more? And at this age group, I often, if I have the time, talk to them about the options of an inhalational versus an IV induction, because sometimes they can have a sort of preference or choice. And I think that helps to empower the child to feel like they have a little bit of control. In that as well, if there's any behavioural concerns, I'd be discussing that with the parent about what kind of things are triggers for this child, what things they do and don't like, if there's any particular things they really like that could be useful for us to get them to have a smooth sort of on the day anaesthetic pre and induction.
Yes.
So really exploring the behavioural thing.
Anything else on the examination that might be a thing for kids of this age?
Kids of this age.
With the airways, anything particular?
I guess I want to look at the tonsils. I'm assuming they'll be fairly prominent.
Anything else?
Specifically to airway, I'd probably just do a fairly standard airway assessment, so neck extension, Malin Patty, jaw protrusion, if you can follow those instructions.
Yeah, good.
I'm not sure. I think you're getting at something specific.
We'll get there. That's it. It's absolutely fine. Now, the parents do mention that this child has had a recent cold. What do you do with that information?
So I guess I want to determine how recent the cold was. So is it in the last 2 weeks or is it more than 4 weeks ago? And then based on that, I want to take a little bit of a history about the nature of the cold symptoms. So, was it cough, runny nose, sore throat, fevers? Was it productive or dry cough? Was there any runny nose with green sort of snot as opposed to clear runny nose? If there was any shortness of breath or need to attend the hospital as a result of this URTI, and then if you had to have any antibiotics for sort of progression to lower respiratory tract infection, and in particular if we've got any history of viral induced wheeze or asthma in this age group that may have been flared by that recent upper respiratory tract infection. And then depending on the severity of the URTI and when the resolution of symptoms would determine whether I need to postpone the procedure for safety or whether it's safe to proceed. It's an elective procedure, so really you're going to be postponing until it's safe to proceed, which should be at least 2 weeks after resolution of the symptoms for this child.
So it sounds like you've got lots of good criteria there. What would be your hard lines that would make you postpone this case?
So hard lines, if the child's acutely unwell at the time that I'm seeing them, and it doesn't tell me when, the procedure is.
So let's say
is it on the day of procedure?
On the day of surgery. And let's say they've just started having this cold. But anyway, what are your hardline markers that would make you postpone?
Yeah. So I guess in my setting, which is scenarioville, I would have a lower sort of risk tolerance than an average paediatric anaesthetist. So if the child's acutely unwell on the day, I would postpone the surgery. But in particular, if there's any really significant symptoms, so a productive cough, green phlegm, fevers, lethargy, constitutional symptoms, any hypoxia on room air, any reduced exercise tolerance, or any shortness of breath or wheeze or sort of respiratory distress associated with the URTI. But I really think in scenarioville, I'd probably err on the side of if he's just brewing a cold, I'd still be inclined to postpone if he hadn't already been postponed, just because of the lack of sort of paediatric anaesthetic assistance and any ability to support him in a HDU capacity post-op.
Sounds good. Now, with this, what is the risk? And let's say let's say the patient was fine from that point of view, but had a recent cold a couple of weeks ago, has a minor cough, but no other warning features. What is the increased risk for this patient of proceeding?
Yep. So the main thing with the recent URTI is the risk of perioperative respiratory adverse events, in particular laryngospasm, bronchospasm, and difficulty with extubation. I think it depends which study you look at, but somewhere between 3 to 7 times the risk of perioperative respiratory adverse events with an URTI in the last 2 weeks. And then obviously it depends on the other patient factors and any pre-existing comorbidities as well.
Yeah, excellent. How long will the airway stay reactive for after a cold?
So after the resolution of symptoms, it's sort of still reactive for 2 weeks. After 2 weeks, it's sort of the airway reactivity has decreased. And then after 4 weeks, you pretty much return to baseline risk. So depending on how conservative you want to be, you could delay 2 weeks or delay 4 weeks if you want to be extra sure that they're back to baseline. The risk being that they catch another URTI because they're a kid.
Okay, good. Let's say this child is fine from that point of view with a very, very minor occasional cough. So it looks like it's resolved. Now, because this patient is lucky, you notice a murmur on auscultation. How do you approach that?
Yeah, so I guess in relation to the murmur, I'd want to assess it in character on auscultation. So getting the child to do some movements, including holding their breath in, holding the breath out. I think you can also do a sort of listening to the murmur with squatting and then with standing as well. And then you're trying to essentially characterize whether there's an innocent sounding murmur or a pathological sounding murmur. So features of an innocent murmur would be sort of a soft, early systolic murmur. I can't remember whether it changes with movement or not.
That's right.
Yeah. And then the ones for more pathological murmurs would be things like a harsh, loud, diastolic or pansystolic murmur, particularly if there's radiation to suggest sort of like radiation to the carotids or radiation to the axilla to suggest a stenotic lesion. And then from there, you need to also match up with the functional assessment of the child. So if they're having any kind of impaired growth, failure to thrive, any kind of functional impairment compared to their peers, that's very concerning for a potential pathological murmur. But if they're otherwise completely well, can run, can walk, can do everything their peers can do, and have all the features of an innocent murmur, then it's less likely to be significant.
Okay, great. What kind of investigations could you do if you were a bit concerned?
So that's concerned. Firstly, it'd be postponing the surgery and you get an ECG, you could get a chest X-ray as well, and then you'd need to probably speak to cardiology and arrange a paediatric echo, which I don't think we have capacity for in Scenario-ville. So that would be quite significant. The child's likely to be able to have to travel to get that worked up. If there was concerning features, though, you'd want a full workup, including a review by a paediatric cardiologist prior to proceeding.
Yeah, absolutely. Let's say you are able to get an ECG. If you were to see something very concerning with a systolic murmur, so let's say this patient has a systolic murmur and it was due to a hypothetical serious pathology, what kind of things might you see on ECG?
Gosh, pediatric ECG is not my strong point.
From what you know of,
I guess
adult ECG.
general things. Yeah, general things I'd be worried about, evidence of left ventricular hypertrophy or right heart strain. That would be concerning from both sides. If there was any evidence of atrial enlargement, so P pulmonale or P mitrale would be concerning as well for atrial enlargement.
So left ventricular hypertrophy or strain, absolutely, because then that would be a sign of what's systolic murmur.
So that's probably some kind of like left ventricular outflow obstruction, something like aortic stenosis or HOCM. Okay. The other thing as well, with children, you can have the dagger Q waves as well for HOCM. If you pick that up, that'd be very bad.
Okay. This patient has no concerns. This is absolutely just a innocent pediatric murmur, and it's early systolic and no issues at all. You decide that you do want to give a pre-med to this child because he's quite anxious. What are your options?
Yep. So common options include midazolam orally, so 0.5 milligrams per kilo, maximum dose 20 milligrams, with care in this child because he's overweight and possibly has OSA. Another option would be clonidine orally, 4 micrograms per kilo, and that takes a little bit longer, so 45 to 60 minutes for onset, but is tasteless and not as gross as midaz, so maybe better tolerated. Other options would be intranasal Dexmed if we have it in Scenario-ville, which no one's clarified for us thus far. So dose would be sort of 2 micrograms per kilo intranasally. And then the other option would be something like oral ketamine. So I think the dose there is sort of 3 to 5 milligrams per kilo. If you had an extremely combative child that you were unable to get another pre-med into, you could also consider IM ketamine, but that would be a last line option and only for a sort of really desperate situation where you definitely needed to proceed with the anaesthetic.
Great. You mentioned the concern of midazolam with someone who's got sleep disorder breathing. What would you have to put in place?
So I think the main thing with the midaz, if you were going to use that, is making sure they're in a monitored environment and potentially even having a SATS probe on them once the midaz has been given and they're a little bit more settled. So potentially giving them midazolam, and then because it's quite quick, I'd probably get them brought into the anaesthetic holding bay with my anaesthetic nurse, or if I have capacity, just to monitor them while they become a little bit more sedated, because you may need to intervene with the airway, particularly if he becomes very sedated and then starts to obstruct his airway.
Okay, great. What analgesic options would you do for this case?
Yep. So tonsillectomy in a pediatric child, firstly, I guess, thinking about whether he's suitable for a day case or not, given his weight, I'd probably be inclined to keep him overnight, at least one night for monitoring post-operatively. The analgesia, I use the Prospect guidelines, so the multimodal analgesia, including paracetamol, 15 milligrams per kilo QID, Nurofen or ibuprofen, 10 milligrams per kilo TDS. I'd give intraoperative intraoperative fentanyl, probably 1 microgram per kilo. You can titrate up to 2 micrograms per kilo, but you just adjust that on the breast rate. Giving them dexamethasone intraoperatively as well, so 0.15 milligrams per kilo, the max dose of 8 milligrams. And then post-operatively, I'd be using oxycodone orally as a rescue analgesic. So his weight, I would be inclined to go with a slightly more conservative dose of 0.05 milligrams per kilo, sort of in hospital Q4 hourly PRN, and then at home would be QID PRN only as a rescue, and providing the parents with lots of education about how to use that safely and how to store it safely to avoid any respiratory depression. The other thing I know that can be quite helpful is actually honey for tonsillectomy. Apparently honey's got reasonable evidence, so you can suggest that to the parents as well.
Is that in the Prospect guidelines as well?
It is, and acupuncture also has grade B evidence, but I don't know how to do acupuncture on a child. I'm not going to suggest it.
Sounds good. Let's say that all sounds great. So you decide to perform a gas induction. What is your, tell me the whole plan for a gas induction in a child.
The gas induction in a child at this age, it would depend a little bit on how cooperative he is, but ideally you get them into the theatre with their parent present for induction, and you have your anaesthetic nurse and your theatre tech and everyone else and surgeons ready to go. If able to, it'd be nice to get ECG leads on a SAPS probe on to the child prior to induction, but if they're very sort of upset or distressed by that, you can put that on after they've been induced. And then for this child, you just essentially holding them up to the face using the T-piece and providing a little bit of PEEP via the bag. And depending on their cooperativeness, you can go for an incremental induction with a little bit of nitrous as well. So you sort of go 2% SIVO, 4% SIVO, up to 6%, then up to 8% SIVO until they're induced, and then dial it back down. Or alternately, if they're very combative or upset, you can go straight to 8% SIVO to get a quicker, more rapid induction. I'm hoping this boy, given his 8, it could be a little bit more of the cooperative side, so we do incremental induction with nitrous. Once you've got them deep, then you probably need a second GPA or a very skilled nurse to then place a cannula, give a dose of propofol, probably 1 to 2 milligrams per kilo and 1 microgram per kilo of fentanyl prior to instrumenting the airway to make sure they're really deep and not going to react to that. I haven't decided whether I'm doing an LMA or tube for this child. It depends a little bit on the surgeon's preference, because I know that often they can do tonsillectomies on an LMA. So I was going to say, once they're induced, then putting the rest of the monitoring on as well. So if you haven't already got to get everything else on.
How do you check depth?
Yeah, so with the sevoflurane, you can look at the end-tidal SIVO concentration, and on most anaesthetic machines, you can put in the child's age to be able to aim for sort of 1 MAC prior to instrumenting the airway, or even a little bit higher potentially. The other thing commonly with SIVO is when they're induced, once they start to get deep, they'll become a little bit more bradycardic, or the heart rate will start to slow, which is an indicator that they're becoming deep. And then the other thing is after you've given a propofol and fentanyl, a really, really good jaw thrust or some kind of stimulation, and making sure they don't react to that before instrumenting the airway. But I guess always having in the back of your mind that laryngospasm is relatively high risk in pediatric patients, particularly if I'm using an LMA. Any
other patient-specific factors? Let's say every MAC in every inhalational induction will be off the charts, but the patient still won't be deep, so I wouldn't use MAC as my guide. But what other patient things besides the jaw thrust would you look at for depth?
I think you can also look at their eyes.
Yeah.
In terms of like where the eyes are facing, because they go through various stages as they go through the stages of anesthesia. I'm trying to think. I've only done this a couple of times. But I think the point at which they're deep, they're just facing forward again, aren't they?
Yeah. Okay, good. Yeah. Neutral.
Yeah.
Neutral gaze, not out, not in, and normal size pupils. Okay, good. Now, during induction and before placing your IV cannula, you notice that the oxygen saturations suddenly are dropping down to 88%. What do you do?
So I would immediately be calling for help, because this is potentially quite a disastrous scenario. I would maintain an FI of 100%. I'd turn off the nitrous if I had any nitrous going, but keep the SIVO going with 100% oxygen and maintain flows of 10 to 15 litres per minute. I would assess whether I can ventilate the child. So I've still got the T-piece in my hand. So with, a two-handed technique and a good jaw thrust, if I'm still able to ventilate, if we're getting any chest rise and fall, and then auscultating as well. No, okay. So if there's no chest rise or fall and it feels like a complete obstruction, it's concerning for laryngospasm, because at this stage I haven't put anything else in the airway. In that case, you want to maintain 100% oxygen. You want to maintain the CPAP. So jaw thrust and good CPAP and a seal. And then I would ask whoever's attended to assist someone to draw up. We haven't yet got a cannula, have we?
No.
No, okay. So you can try deepening your anesthesia, but obviously at this stage I'm not getting any SIBO in, so I can't deepen it, and I don't have a drip, so I can't give propofol. So the next option is you give succinylmethonium IM, and a pediatric dose is somewhere between 2 to 4 milligrams per kilo IM into the bicep to break the laryngospasm. So I usually draw up the IM dose for the child of their weight before I start a gas induction. So hopefully we'll have had that already ready. I can just ask them to draw it up and give it.
What dose would you give in this child?
This is a bit tricky because he's a bit overweight. I think I'd be inclined to give 2 milligrams per kilo IM, because for the laryngospasm, you don't need a full sort of paralytic dose. So 2 milligrams per kilo should be plenty IM to break the spasm. And then if I were to need any further paralysis, you might need a higher dose. But I think in this case, 2 milligrams per kilo would be suitable.
Is there anything else you might want to give IM in the context of this patient becoming hypoxemic and giving sucks?
Yeah, so you usually want to give atropine as well to prevent bradycardia associated with sucks and hypoxia. And I think the dose when you give it IM is 40 micrograms per kilo.
Okay, yep. So essentially you thought it was laryngospasm. That was pretty fair. You managed to give sucks and were able to start ventilating the patient again. What do you do now with the case?
Well, we've had a fairly major respiratory adverse event already, and we haven't even gotten an airway. And so I think I'd be discussing, I would call another GPA to attend, and I would discuss with them sort of the pros and cons of proceeding with the case versus allowing the child to wake. And we haven't yet put an airway in, so just allowing the child to wake and postponing the case. I guess the other thing would be thinking about what happened to cause the laryngospasm, if there was any sort of unexpected stimulation, because I hadn't yet instrumented the airway, and presumably the surgeons or hadn't gotten near the child. So just thinking about other things that might have contributed to that and how well we can manage it in the current setting. It's elective, so I'd be more inclined to wake the child and sort of plan again for the anaesthetic.
Let's say you're having no problems ventilating at all. So you've essentially had a laryngospasm induction and it's good now. And what are your pros of going ahead and what are your cons of?
I guess the pros are the situation has resolved and we can, the child's otherwise well, we can probably still proceed with surgery as long as everyone, sort of the surgeon and, in consultation with the GPA, if we're all happy to proceed. I think the other thing is once that's broken, you can probably then get an IV cannula in, and then if it were to happen again, you're in a much safer position because you're able to manage that a little bit more easily and you can give propofol to keep the child deep enough. The cons, I think, is just thinking about where we are and the assistance or lack thereof that we have in that we don't have a paediatric anaesthesis, and that if the child's already had an episode of laryngospasm, it's very high risk for laryngospasm at the end of the procedure and even during the procedure. If we're using an LMA with the shared airway, there's a risk of secretions and blood going down and causing that to happen again. So I'd be very worried sort of about the sort of extubational end of the case phase and then recovery and PACU for this child if we did proceed.
And in terms of the extubation, you would essentially have to go through the risk of them waking up anyway, except they wouldn't have an airway in. Good. That Viva. Well done.
Okay. I didn't know where that was going.
No, some of these are just a discussion of what you do. But let's go through it from the start. So I'll actually I might share screen. So anyone who's you can, if you're listening on the podcast, there'll be a YouTube video of this. So essentially creating this Viva essentially for anesthesia assessment. So like I said, the specifics of any of the exams are not in here, but then there's lots of general stuff for any pediatric exam, which I've absolutely included. So, this is just a decent Viva from the point of view of lots of different pediatric common things that occur. So essential anesthesia assessment for the peds patient, critically thinking about the, cancelling continued pediatric patient with an URTI. I've added in the murmur there as well, analgesic options and the management of laryngospasm, kind of the bread and butter stuff that everyone hopefully learns in their first couple of years. So that was the thing. So I thought your pre-operative assessment was fantastic. Essentially, you're going through all the usual things that really matter. Congenital issues, histories of birth. The one thing I prompted was engaging the patients, and checking for a pre-med is often a thing. What you did so well then was you're synthesizing information like, okay, this patient's weight should be around 24, 25 kilos. They're 30. So this means something, difficult IV access, OSA. And you mentioned those things and then you went to them. And that's a really useful thing, if definitely in the exam, because you're taking existing knowledge that you have and then extending it. But also in real life, because you're always trying to predict how this particular patient will go wrong. So I thought that was fantastic. And then, you also just mentioned, I think, URTIs are common in this age group. So I agree to actually not just say your usual assessment, but actually, so I'm looking to see if they've had any recent colds, because that is common. So common things and things that you've delineated or you've said might be predicted from the weight was great. So then, yep, we talked about the need for a pre-med examination. Absolutely. And you said really good things about that. So airway exam, cardiorespiratory. Like a lot of people, I think, these days, are getting a little bit lazy with auscultating lungs and the chest. And so I think it's great that you mentioned that, but then you get the murmur. If you don't get the murmur, I mean, this exam, you lose so much out of this exam and in real life. At this age, potentially teeth is the other thing I'll ask most kids or most parents, just I'm worried about loose teeth everywhere. And investigations, you said polysomnography, and there's nothing relevant for this particular patient because we've kept them pretty well. Your answer for the URTI, so the answer for the URTI, first of all, just to add that in our RG exam or the GPA exam, to always mention scenarioville is just such a useful thing. So you're saying, look, in the context, an URTI in the context of scenarioville, I have a lower threshold. That's great. Just say that for almost every level of question. It's a really useful thing. Because it's not just the fact that RGAs is thinking about this, but when I'm working in private, when I'm working in a non-tertiary center, when I'm working in my hospital that doesn't have certain facilities, I'm always thinking about where I am. And I think it's great that you mentioned that. You very quickly said lots of useful things about it. And I really encourage anyone who's listening to this, like, you just need to be able to say things like, you're concerned about how, the duration of the cough, when it was, what the temperature is, production of cough. Do they have wheeze auscultation? Do they have a history of asthma? Even parent smoking is a risk factor for these. So you gave lots and lots of useful information. Not only that, when I asked what are some of your, so that's all good information. And then when would you cancel? You had an answer for that, because everyone needs a line in the sand that makes them go, I'm not going to proceed. And it's very useful in this case to be more cautious. You had some great figures. So really, I'm worried about respiratory complications, bronchospasm, laryngospasm. And you mentioned, you almost got this, like, I've got this data here from probably a CACCP article, 2 to 7 times increased risk of all of these, which is great. Ideally 4 weeks. I mean, even airway reactivity, I've seen some information saying up to 6 weeks. So realistically, we proceed, because airway reactivity in a patient that gets cold every month or every few months is just not practical. But I have a lower threshold cancelling if there's other factors in play, including scenarioville. Okay, they've got a murmur auscultation. I'll just move to this table, but everything you said was really useful. Pause the video, have a look at these things. None of us are going to be pediatric cardiac experts, but your approach was very reasonable. Things like, do they have any congenital history? Do they have, are they able to keep up with their peers? Essentially, they're talking about does the patient have any significant concerns? And you mentioned lots of the things like there's no thrill, apex beat not displaced, it's soft, short duration, no radiofemoral delay. There's a whole bunch of extra things, but I think most of us would look at the functional capacity of the child and any other particular history, and this, I guess, the severity of the murmur. This is a very specific question. Often ECG will be the only thing you have. And I love that you weren't scared by this question. You just went, well, I'd be concerned by LVH, RVH. And these are very useful things, because these are two of the conditions, or HOCM and critical stenosis, are two dangerous conditions to exclude before surgery. And they're usually associated with LVH and left axis deviation as well. So that's kind of an extension. I don't think, in certain junior exams, you'd get this level of detail, but I thought I'd chuck that in just for knowledge. Would you give a pre-med? If you gave a pre-med, what you do? Again, really good to say the thing that you're giving, the dose and some level of risk. So, you gave the risk you gave the dose, you said, I'll be concerned of this patient, again, relating it back to the situation, clonidine, ketamine, and, you mentioned the full story of this. So you mentioned midazolam, you mentioned Dexmed, I think you mentioned clonidine and ketamine and iron ketamine. So I'm not having to get a lot of answers out of you. You're just giving me all the information. I just omitted that question because I didn't really need it. Analgesic options, great. And you gave me a good selection of things. And you just decreased the dose of oxycodone afterwards and talked about safety. So you had bonus marks for that as well. Perform the gas induction. Having a format for this is really useful. So it sounded like at the start you went, what are the personnel I need or staff? So assistants. So that's monitoring you talked about and how you place something if possible, which is again realistic. So it sounded like you've done pediatrics by doing that. You mentioned the equipment as you went along. Maybe the extra thing I'd say was I'd have all my emergency drugs ready and check.
Yeah. Which is hilarious because that's something I actually do in practice is I always have the emergency drugs ready, so I just forgot to say it.
Yeah, that's right. And because it's hard to know exactly what the examiners want in that question, I asked something like, what's everything you'll do? So I try to be very direct. The examiner's questions may not be as prescriptive, but I try to be as prescriptive. So there's no room for error. But you had lots of things that you were already told me previously as well that you have the tubes ready, and we didn't get to emergency drugs, but that's where. And you told me how you dial up things. Like again, the reality, you start 2%, 4, 6, 8, or if they're distressed, you go straight to 8. That's exactly what we seem to do. These days, I don't use nitrous at all. There's a study. The environmental impact of nitrous is one thing. The extra speed of it is so minimal that I was compelled by this evidence that I saw someone present in one conference somewhere. So now I just don't use it. But also having that extra oxygen, I find pretty nice. I'm not a pediatric anesthetist, so those pediatric anesthetists will be able to weigh in with this. And you had a good system for monitoring, telling me what you do when and giving the profile and the fentanyl at the time. Yeah, so for me, depth it's not MAC, it's really just, is the patient still wriggling? Are they moving? I look at a bit of a gentle jaw thrust and firmer as I go, and I look at the eyes and they've got to be essentially straight. They're often really divergent for a long period of time or downward facing. Then they get straight with normal sized pupils, not small, not big. And that's usually where you think they're ready. There's a rule in pediatrics that says when you think they're ready, they're not ready, and there's minimal harm in getting them deeper as well. But we have the IV cannula that really helps with that. I think your planning for this for the laryngospasm was great. So you essentially call for help, which is absolutely the thing you do in any of these junior exams. In the final exams, for certain things, we people wouldn't ask for help, but I think that was great that you did that. 100% oxygen you mentioned. You wanted people to, you mentioned the things like maintaining the airway, giving the jaw thrust, trying to maintain PEEP. And because you don't have propofol, you give SUX. So succinylmethonium, it's a weird one because 4 milligrams per kilogram of SUX is 120. I'd just give the full 100 because that's potentially the thing that I drew up. But even if you were get somewhere along that range, we don't know the doses. They're not really dose. We haven't done dose finding studies on these, so that was good. Previously, again, atropine IM, I've just given 20 mics per kilo in the past, but if you were to give 40, the patient will tolerate that as well. But I would. Yeah,
I think I was reading it somewhere when I was studying before, and I noticed for the first time that it suggested that dose for IM. But
yeah, cool. I'll stand corrected on that.
I don't know. I think either would be fine.
And then we kind of covered all this anyway, mainly because you've already told me the laryngospasm, but we didn't have ththese complexities, which I've included if I made the case more complex. And would you continue with the case? Yeah, look, it's mainly just the discussion of it rather than a hard and fast rule, especially in scenario. This was a final exam situation in a more tertiary hospital. Everyone would probably continue because all the risk is already borne out. And now we put the tube, the LMA, and whatever we're doing, it will be fine. And we got all the help. But in scenarioville, if we thought that this patient had super reactive airways and some level of concern, you might not want to go ahead. I still think most people would go ahead just because you remove that risk, and the next person, they'll still have a patient probably post-URTI with a cold, with potential for laryngospasm, and now we've got the same issue. So I think a lot of people would proceed with that logic. So you could probably say any logic in this exam as long as it was reasonably well thought out. Yeah, that's great, Erica. Any questions?
I was actually thinking, so after that situation where you have the laryngospasm at induction, and say if you did decide to proceed, would you definitely want to tube the child so that you're like, at least intraoperatively, you're not going to have any more laryngospasm, or could you still consider using an LMA? Because I guess the risk is that then when you're trying to extubate, you potentially have a risk of laryngospasm then when you pull the tube out.
I think it could go either way. I think I think in reality, someone who's already had a laryngospasm, if you put the tube down, that removes the intraoperative laryngospasm risk, which is a really good thing. And we can get the patient as awake as possible prior to removing. And that's what I'd say. But in reality, like in real life, these patients, they wake up in a very slow way, if you found. And so sometimes you're like, the patient's not fully awake and you're now in a light plane of anesthesia. You either got to just keep it until they're really, really awake, or people just end up pulling it deep, or some level of position, and just manage it. And it really is just anaesthetist to anaesthetist dependent on how they do it. But I think talking through it's probably in the exam, it's probably easier to talk through saying, they've had laryngospasm, I'll put a tube in that takes away the risk of laryngospasm intraoperatively, and I'll wake this patient up quite awake. Other people would absolutely take the tube out very deep and have them spot venting. And I think that's a fine suggestion as well. But it's just easier to talk through it with a tube in.
Yeah, no, fair enough. Thank you. I need to revise the murmur stuff. That's not quite in my head as well as I'd like it to be, but otherwise all good.
I feel like that answer was easily a pass answer. Like we're not in that particular exam where we're not getting into the super detail of it. So honestly, I wouldn't waste too much time on it. Yeah.
No, all good. Thank you.
What do we still have to do for the future? I think we've got a trauma one coming up, or you can choose?
Yeah, I'm at the moment, my study group and I are just going through all the previous exams and kind of getting through those questions. And then I did a session yesterday where we just went through the anaesthetic crisis manual and just did crisis after crisis. So yeah, I think anything and everything is good at this stage. I've still got a little bit of time to go. So just trying to pack all the knowledge in.
Great. So let's go with thanks everyone for watching and listening. See us again next time for another Junior Anesthesia Viva. And yeah, we'll grill you on something else. Well done, Erica. Really great.
Sounds good. Thank you.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.